And then there are certain structural definitions. For example, is the ratio of clinicians to clients in the range of 10 to 1, or is it higher? Does the ACT team have regular meetings? The frequency of meetings is part of the definition. Is there a certain percentage of access to a psychiatrist on the team? That's another part of the definition. And all of that is then used to come up with an overall score that is a reflection of the fidelity of the program to the principles of assertive community treatment. So then there's a couple of implications in terms of fidelity, because I mean at the broadest sense, if you're getting contracted, if you're supposed to be providing assertive community treatment, then the question is, well, are you really providing it? A fidelity scale becomes one way of evaluating that. There are, of course, other ways of determining performance indicators. But let's talk about what has been studied in terms of fidelity assessment and ACT. And one of the things that's very interesting is Eric Latimer did a study of the cost effectiveness of ACT programs. He really had two important conclusions. One was that ACT was found to be most effective for people who had more frequent psychiatric hospitalizations, and he was, remember, looking at the cost effectiveness of ACT, and so that makes sense. We know that the highest ticket item in any kind of psychiatric treatment is inpatient treatment, and so it only makes sense that the people with the highest amounts of inpatient treatment are going to be those who respond best to an intervention that has that as one of the goals. But the second thing that they found was that the level of fidelity, the degree to which a program adhered to the basic principles of ACT, was also related to the cost effectiveness. Higher levels of adherence to the principles of ACT, as determined by fidelity, were associated with greater cost savings than lower levels of adherence. And I'm going to come back to fidelity in a second when we talk about dual disorders. So one of the issues then became, or one of the questions that I wanted to just put out there and talk a little bit about, and that we will be able to return to, is what can we do, or what are people trying to do to address areas of ACT in which ACT appears to have a lower than desired impact. And remember, those areas of ACT included social functioning, included substance abuse, they included involvement in the criminal justice system. I don't have a slide on it, but so far there has not been much research focusing on the effects of ACT in terms of physical illness. But these are other potential areas. Family relationships. I mean, there's a little bit of research looking at family satisfaction with ACT programs. Very little research looking at actual family burden or the quality of family relationships between people receiving services on ACT teams. There's also been very limited research looking at the role of ACT teams in teaching people the rudiments of how to manage their psychiatric illness more effectively. We can think in terms of illness management being things such as the ability to prevent relapses, the ability to cope with symptoms, and so on. Now, we know that one way that ACT can help people prevent relapses is by going out and monitoring symptoms and providing medication and the like. But there's a potential role for ACT in terms of teaching illness self-management as well. So what I want to do for the next couple of minutes is to consider some of the potential remedies or ways that ACT teams can or are actually addressing some of these issues. Now, one of the issues, or one of the approaches, has been the question of how ACT can be more effective at improving substance abuse outcomes for people with severe mental illness. Now, the importance of this is that we know that substance use disorders, alcohol or drug abuse, are highly prevalent in people with severe mental illness. The lifetime prevalence rates are generally thought to be in the 50 to 60% range. That compares to a lifetime prevalence of about 15% in the general population. So they're 3 or 4 or 5 times more likely to have substance use problems than people in the general population. And we know that substance abuse is related to lower levels of engagement in mental health treatment, precipitation of relapses and rehospitalizations, and a host of other problems, including legal, social, health, living, and other kind of problems as well. So the ability to engage and to treat people who have co-occurring substance use disorders is really important. And the fact that people with substance use disorders often are in and out of treatment has made people feel that the ACT model might be a real appropriate vehicle for treating people with co-occurring disorders. However, just accessing people, in other words, just engaging people in treatment, by and large, doesn't necessarily improve outcomes. It does matter the kind of treatment that people are getting engaged in. And so it's possible that ACT in its own right hasn't had a significant effect on improving substance use outcomes, mainly because early studies of ACT really didn't focus on implementing any particular model of treating dual disorders. So there is now some growing research on the application of ACT and the use of an integrated dual disorder treatment model as the guiding vision or the guiding model for the ACT team. And there's some research indicating that ACT is a more effective vehicle for delivering services for co-occurring disorders. Although the studies have been very rigorous, because the studies have tended to compare assertive community treatment teams that are equipped to provide integrated treatment for dual disorders with standard case management teams, but that are also equally equipped to treat people with dual disorders. So here we're looking at the delivery system for providing integrated treatment for dual disorders. So one study done by Bob Drake, and this is a study that gets us back to fidelity, back in the mid-1990s, compared ACT with standard case management across 7 different community mental health treatment teams, in which each of the different teams, both ACT and standard, received a training in the principles of integrated treatment for dual disorders. Those principles including outreach, so that's one of the complicating factors. I mean, outreach is a principle of even standard case management treatment of integrated treatment. So it's not like you're comparing a purely clinic-based service with an assertive community treatment team. Other principles being motivation-based intervention, comprehensiveness of services, focus on reduction of harmful consequences, taking a long-term perspective, and there are many specific treatment components as well, like group interventions, individual-based, and the like. Overall, what the study found was that there were very modest effects benefiting or supporting the assertive community treatment model over standard case management in a number of the outcomes, in particular in terms of alcohol use days, some of the quality of life outcomes, and so on, although the effects weren't huge. But then a secondary analysis looking at the effects of fidelity, indicated that one of the reasons perhaps we weren't seeing greater differences than we were expecting is that the quality of the implementation of ACT varied somewhat from center to center. And if you explored the relationship between the fidelity of the program to the outcome, what you found is that the higher fidelity programs had better outcomes. So what this does is it takes the 7 centers, breaks them into high fidelity and low fidelity centers, and then looks at the rate of remission of substance use disorder over the 3-year treatment period of the study. And what you can see is that the high fidelity programs had much higher rates of remission of substance use disorders than did the low fidelity program. Now there's another study comparing ACT with standard case management. This one, I was very much involved in it, done in 2 urban areas in Connecticut, in Bridgeport and Hartford. And again, a similar design in terms of the integrated treatment for co-occurring disorders provided on a standard case management team as well as provided on, as compared to provided on an ACT team. The overall findings here did not indicate significant differences in terms of substance abuse or mental health outcomes between the 2 different treatment programs, although both of the programs across both sites saw significant improvements in substance use disorders, mental health outcomes, and hospitalizations. Now, interestingly, the 2 sites differed in their use of hospitalization at baseline. And when we looked at the effects of the ACT intervention, we saw that it actually interacted with the amount of hospitalization that occurred at the different sites. And as we expected, what we saw was that the site that had the higher rates of hospitalization prior to the study, that ACT was successful in reducing the rates of rehospitalization for those clients, as compared to the other center in which there were relatively lower rates of hospitalization where there was no difference.